So just a brief overview about the causes beyond just the endocrine. We need to understand what endocrine factors can influence the blood pressure besides the adrenal. So we know that blood pressure basically depends upon two phenomena: how much is your heart pumping and how much is your peripheral vascular resistance. Now, one of the major determinant of peripheral vascular resistance is the calcium level. So, conditions associated with hypercalcemia, like hyperparathyroidism, can cause hypertension, which becomes important. Cardiac output will depend largely about the fluid status, and the major determinant of fluid in the body is actually the sodium level, which again is hormonally regulated. Growth hormone also has a role in terms of fluid. The second determinant of the stroke volume is how much is the contractility, and that contractility depends upon the heart rate governed by the thyroid as well as the adrenal gland. So if you have thyrotoxicosis, you will have increased heart rate and increased contractility, causing a hypertension which is there. And then of course we have got the entire system, the renin, angiotensin, aldosterone system, which is going to act in terms of the sodium absorption, which becomes important. And we of course have the cortisol and the catecholamine, which has a direct impact in terms of the cardiac output. So there are multiple hormones which are affecting the regulation of blood pressure. So endocrine conditions causing hypertension will include, Dr. Alapan?
We include the thyrotoxicosis first one.
Yeah.
For hyperparathyroidism, we look at excess
Yeah.
doping cause will cause like cortisol excess, like Cushing syndrome will be there.
Yeah.
Pheochromocytomas, tumor
Yeah.
catecholamines, like it can cause, and other causes of hyperaldosteronism also cause.
And other causes will include growth hormone excess as well. A word about the renin, angiotensin, aldosterone pathway. We know that most of the sodium which is actually filtered in the glomeruli is reabsorbed at the level of the proximal tubule, and it's around 97%. So only 3% of it is remaining. Out of these 3%, most of it, approximately 2%, will be reabsorbed at the level of the collecting duct. And this is done using a very important channel which is known as the epithelial sodium chloride channel. Now this channel is unique that it takes sodium and chloride out. Now what is unique about this channel is that the rate of efflux of sodium is faster as compared to chloride. So the lumen becomes electronegative. And when the lumen becomes electronegative, positive things like potassium, like calcium, magnesium, all those things, and proton will be lost on that. So that is an important mechanism there. This epithelial sodium chloride channel is largely regulated by the aldosterone. Now, when I talk about aldosterone, I always say that the only role that aldosterone does in terms of mineralocorticoid or the sodium activity is to increase the availability of the ENaC channel at the membrane. It is basically pushing these epithelial sodium chloride channel from the let's say in the cytoplasm, it goes towards the membrane. So it's like you are sending your messengers to get things inside. That is the mechanism which is there. Now chloride is also coming in, but it is coming in slowly. That's why you have a electronegative environment in the lumen which drags out potassium, proton, magnesium, and all the positive ones like calcium. So what it means is that if you have increased aldosterone receptor, or ENaC channel activity, you will not only be retaining a lot of sodium chloride in the body, you will also be losing potassium, proton, magnesium, and calcium. And therefore, hypokalemic alkalosis will be a hallmark, which Dr. Sandeep was talking about in the setting of somebody who has a increased renin, angiotensin, aldosterone system. Now, an important point to remember is that these children will not develop edema. So they will have hypertension, but edema does not happen. Why?
Because sodium after a level, it doesn't increase that much because of ANP, sir.
Yes. So as soon as your sodium levels reaches above 145, 146, the atria will start sensing them. They will produce atrial natriuretic peptide. They will shed this sodium. So the major biochemical abnormality of hyperaldosteronism is not hypernatremia. It is hypokalemia. While the major problem of the mineralocorticoid deficiency again is both hyponatremia and hyperkalemia. So that threshold effect of ANP becomes important. What's also important is that you will also have hypercalciuria. So there is a chance of nephrocalcinosis happening in the setting of these scenarios. Suppose you have a child who has got hypertension because of other causes, let's say a secondary hypertension because of obesity or hypertension because of the adrenocortical cause. What will be more damaging? Same level of blood pressure. What will be more damaging for the kidneys and more damaging to the heart? The essential or the adrenocortical?
Identical will be more damage.
Why?
Because direct toxic input to aldosterone on
So because of the vasoconstriction, which is going to do, the local effect will be there, and there this calcium deposition may also happen. So for the same level, the individuals do much worse. This is particularly true for older individuals. So as we say, 5% of persistent or refractory hypertension tends to be adrenocortical. These patients will do worse compared to those who have essential hypertension. Yeah. Now, of course, renin is produced via the macula densa of the kidney under the influence of potassium levels and fluid depletion, and this converts angiotensinogen to angiotensin 1, which is converted via the lung, the ACE, the angiotensin converting enzyme, into angiotensin 2, which is a very, very important determinant of blood pressure. What are the major actions, Nimisha, of angiotensin 2?
Causes vasoconstriction. It will convert to aldosterone and will help in sodium and water absorption.
Okay, and third?
Thirst.
Yes, so it is going to combine with all the mechanisms. So ANG2 is basically doing everything to increase your blood pressure by causing constriction, the vasoconstriction. It is also stimulating thirst, and it is pushing the adrenals to produce more aldosterone. So this is a mechanism by which your blood pressure will go up. You also have other agents which play a role in aldosterone regulation. I'll talk a bit about how ACTH and AVP may have a role in terms of these regulations which may be relevant, but this can happen at a subsequent level, and you need to also understand that problems may happen in terms of the issues of the ACTH activity may also regulate aldosterone. So what is the effect of ACTH on aldosterone secretion, Dr. Vibha?
ACTH increases the aldosterone secretion synthesis early cycles.
So you will say basically that out of the entire aldosterone which is produced, let's say you have got 900 nanograms, maybe only around 50 nanogram is because of ACTH, the other is because of ANG2. So this may be a minor role, it may not be relevant clinically. What will happen if ACTH starts regulating the production of aldosterone?
ACTH will start regulating the aldosterone, then it will be like a glucocorticoid remedial.
Remediable aldosteronism. So you will have.
Yeah, right. Then it will produce the hypertension, and this hypertension will be curable with giving glucocorticoid.
Yes.
Patient will present in a younger age group, and there will be the family history of stroke and the hypertension as well.
So we'll talk about that in terms of the promoter switch, which happens in that scenario. You will have the ACTH, which is regulating the process of the cortisol, the production of aldosterone, and that may terminate in a scenario where you have refractory hypertension, which will improve over time in that perspective. Okay, so that is the overall pathway. Atrial natriuretic peptide is something which is going to override in terms of the clinical scenario, and that is something which is going to do the counter effect. So ANP is going to inhibit the aldosterone secretion, it's going to increase the sodium loss. So it's a in a way you can say antagonist to aldosterone from that perspective. Dopamine is also an antagonist which is there, which is going to work in that regards as this somatostatin. So these are the major problems which are there from that regards. Now, cortisol, we have discussed in much more detail, can also act on the mineralocorticoid receptor, and this cortisol can cause hypertension because the affinity is similar. Which condition will cortisol cause more effect on the mineralocorticoid receptor? And how is it prevented?
Which conditions?
So, how is this cortisol effect on the mineralocorticoid receptor prevented?
By the enzyme called 11 beta hydroxysteroid 2, sir, which converts cortisol to cortisol at the receptor levels.
So, in what conditions could this cortisol still be acting on the mineralocorticoid receptor, causing hypertension and hypokalemic alkalosis.
So in the condition where there is a deficiency of this enzyme,
Yes, definitely.
or if the cortisol levels are too high that it overwhelms the capacity of that enzyme.
So typically ectopic Cushing syndrome, ACTH resistance, when you have the levels who are very high, or you're using drugs which are resistant to 11 beta HSD2, which is there. Do you know, Dr. Nimisha, of any medicine which inhibits the effect of 11 beta HSD2? And then it is going to cause. So we talked about congenital defect, acquired issues which may happen. And those agents can cause hypertension, hypokalemia, alkalosis because they are inhibiting that. So one, we talk about treatment. Alapan? Carboxynone is one which is used for treatment. Licorice. Licorice is something which cardiologists always ask about on history because that's going to inhibit the 11 beta HSD in that perspective. So 11 beta HSD converts it into cortisone, which is an inactive form.